which is diabetic kidney disease, and the title of this talk is Diabetic Kidney Disease: the Past, the Present, and Hopes for the Future. So I have no disclosures. I have done none of the work that I will present. As always, when a clinician is talking about scientific work, the presentation will include an excess of complicated summary diagrams. I'll present primary data as best as I can. So I consider myself an interpreter of and an ambassador for the hard work undertaken by the principal investigators, statisticians, trial designers, research coordinators, clinicians, and patients who gave so much of themselves to generate the data on which we base our medical practice. So not long ago, I heard a talk. It might have been in this room. The clinical researcher, I think. And the speaker was very enthusiastic about the prospects for new therapies for IgA nephropathy. And the speaker was talking about SGLT2 inhibitors, endothelin receptor antagonists, and all this sort of stuff. And said at the end of one of the slides, said, "Aren't you glad that this just isn't a plain old diabetic?" Which I thought was a strange thing to say. It was like, perhaps I've missed something. Perhaps I missed the memo that we've solved diabetic nephropathy. So I thought it'd be good to educate myself a little bit on where we've been regarding the management of diabetic kidney disease. Okay, so this is our outline. Briefly discuss the epidemiology, and then kind of go through a little bit of the history of treatment for diabetic kidney disease. I guess I always considered myself a history teacher trapped in a career as a doctor. So we'll sort of go through where we have been and what we plan on doing. Okay, so this is a slide from an eminent diabetologist, Kathleen Tuttle, who I think won the Peters Award at ASM this year. And there are 537 million or so people worldwide who live with some type of diabetes, mainly type 2 diabetes. What she meant to write here was that half of the chronic kidney disease cases can be attributable to diabetes. And even though our world includes an excess of individuals who develop end-stage renal disease from diabetic kidney disease, one can argue that they are the survivors, because over 90% of patients die from some sort of heart disease before they even reach end-stage renal disease. So these diabetics somehow climb the hurdle of heart disease and then are left with the misery of kidney disease. And sort of as a sneak preview, this is why, for many reasons, which I'll go into, but I think this is why so many of the trials of new diabetic drugs are congruent and look at heart outcomes as well as kidney outcomes. So, anyway, in the United States, no? Put it down here. I'll move it around. So in the United States, 59% of incident, and this is from the United States Renal Data Service, 59% of incident end-stage renal disease fail some form of diabetes. Okay? They have a lot of other diseases like heart failure, COPD, things like that, but 59% of patients, incident patients in the 2021 patients from the 2023 USRDS report had some form of diabetes. And this has been the case for several years. And I suspect that if we extended the calendar out to the left, this line really would be unchanged. And in the chronic kidney disease population, and this is basically a subset of older individuals looked at by the USRDS with various types of Medicare insurance, diabetes, either type 1 or type 2 diabetes, accompanies chronic kidney disease. Whoops. At every stage of the disease. Now, of course, this doesn't involve causality, it's an association. There are probably lots of people in the subset who develop end-stage renal disease, other causes apart from diabetes. But in the chronic kidney disease population and the end-stage renal disease population, diabetes is the constant companion of our patients. So I've given a few discussions on the cell biology of diabetes in the past. This is going to be primarily a clinical talk. But I thought it was important. So as a result, I thought it was important to begin with a survey of the pathology seen in diabetic kidney disease. This is apparently normal glomerulus, probably cut a little bit thick because it looks a little cellular to me. But this is early onset diabetes with mesangial expansion. The beginnings of Kimmel-Steele-Wilson lesions here, overt Kimmel-Steele-Wilson lesions throughout this glomerulus, a really frightening, very end stage finding in diabetes is the formation of microaneurysms. And oftentimes these microaneurysms can burst, leading to rapid obsolescence of glomeruli. And of course, this is an end stage glomerulus here. Now, I think those of us who think of inflammation in the kidney automatically think of things like lupus or crescentic GN or IgA, things like that. It's very important, and I'll show this on the next slide, to show you or to demonstrate to you or to tell you that this is a wildly inflammatory lesion. What we're looking at here is a wildly inflammatory lesion caused by the convergence of a number of inflammatory pathways. Now, I'm a terrible medical artist, but fortunately, Dr. Tuttle's group can employ some people who are better than me. And you can see here, she's divided this slide into two types. One, metabolic disturbances. And let me say, from my opinion, I think that hyperglycemia is the prime mover in all of this. Without hyperglycemia, nothing happens, okay? There's metabolic disturbances, hemodynamic mediators, inflammation, and fibrosis. All of these interact with each other, leading to extracellular matrix expansion, cellular hypertrophy and proliferation, leading to glomerulosclerosis, which we tend to look at. But one must also understand that there's a lot of tubular interstitial inflammation and fibrosis. And here, she's identifying some of the more well-known inflammatory mediators, including reactive oxygen species, advanced glycation end products, angiotensin II, and aldosterone. There's epigenetics with histone methylation. I gave a talk a couple of years ago on TLR4, on toll-like receptors, and SGLT2 inhibitors. So the innate immune system is also involved in the pathogenesis of diabetic kidney disease. And it is a feed-forward cycle of pro-inflammatory and pro-fibrotic factors, some of which that are listed here, that lead to the diabetic kidney phenotype. So I'm not going to really discuss the cell biology about diabetes anymore. I've tried doing that in the past. But it's really important for especially the young folks here to understand it may not look very inflammatory on the biopsy, but this is a wildly inflammatory lesion, and we need to intervene somehow on the inflammatory process. And goodness knows people have tried, okay? So this is a review article from George Bacris and colleagues, and it kind of shows in a larger way where we've been. Okay, so initially we had no specific therapy for chronic kidney disease and diabetics, and individuals would lose GFR at the rate of 10 mils per minute per year. Then we got RAS blockade with ACE inhibitors, angiotensin receptor blockers, non-steroidal mineralocorticoid receptor blockers, SGLT2 inhibitors, and not put on the slide, but something I'll spend a little bit of time on, are GLP-1 receptor agonists. Okay. And again, it's not like people haven't tried to intervene on some of these inflammatory pathways. It's just they've been colossal failures, okay? An attempt to modify the protein kinase C pathway was a failure. Endothelin antagonism, I think in this talk that I referred to at the beginning of my discussion, the speaker also said everybody's going to be on an endothelial receptor blocker, you know, every year it's going to be the ACE inhibitor of the future. Well, it's been tried in diabetes and a colossal failure. TGF inhibitors have been a failure. Sulahexide, aliskiren, so in other words, some sort of dual therapy with a direct renin antagonist combined with an ACE inhibitor, a failure. Two different studies, Nephron D from the VA and the On Target study, showed that in fact combining ACE inhibitors and ARBs in most cases was harmful, not helpful. And of course, the unkindest cut of all, I think a lot of us were very, very optimistic about bardoxolone and its powerful antioxidant properties as a way of modifying kidney disease. Well, it turned out it had massive cardiovascular toxicity. So let's circle back to maybe the beginning a little bit, okay? In 1975, a pediatrician noted that young children with type 1 diabetes mellitus had very elevated GFRs, and that this elevated GFR pathological process normalized with insulin. And this set off an investigation by a number of people, particularly this person, Barry Brenner, to determine whether this phenotype could be duplicated in animals. Okay? So he took a bunch of Tom Hostetter, who used to be the head of nephrology at Minnesota. Brenner, I don't know who Janet Troy is, but made a bunch of animals diabetic with streptozotocin. Some animals were allowed to have severe hyperglycemia. Others were treated with 2 units of NPH insulin on a daily basis to have moderate hyperglycemia. And the phenotype seen by this pediatrician was to a certain extent duplicated. The control animals had a single nephron GFR of 48.9. Those animals with severe hyperglycemia were evidencing almost like a DKA phenotype of being very volume depleted with acute kidney injury. But those animals that were maintained with moderate hyperglycemia had what we call a hyperfiltration phenotype. Okay. And, you know, this is all ancient history. Why am I telling you all this? I'm telling you all this because this was a discovery made by nephrologists, okay? And the therapy was thought of by nephrologists. And that's on the next slide. If I can get there. Okay, so 3 major papers in the past. One was called a collaborative study from Ed Lewis on the use of ACE inhibitors in type 1 diabetics. And then 2 rather large studies with angiotensin receptor blockers, Renal and IDNT. These were all published between 1993 and 2001, and leads to what you'll see throughout this presentation, which is a proliferation of survival curves. Okay, and it's important to realize that no matter how you slice it, okay, whether you have people with moderate kidney disease, high-grade proteinuria, not so bad kidney disease, type 1 diabetes, type 2 diabetes, made absolutely no difference. Okay. Renin-angiotensin system blockade was kidney saving. And in fact, it's more than kidney saving. Right? So, because if you look at the title of the slide here, I say that ACE inhibitor and angiotensin receptor blocker therapy saved lives, kidneys, and hearts. Well, the collaborative study group published their work on ACE inhibitors in type 1 diabetes with nephropathy in 1993. SAVE, one of the original heart failure trials looking at captopril as an intervention in patients with left ventricular dysfunction, was published in 1991, and SOLVED, which examined the role of enalapril in the same population, was published in 1992. So in the early 90s, we have a demonstration that renin-angiotensin system blockade saves lives, saves kidneys, saves hearts. You notice I said hearts last nephrologists. And I didn't have time to put this in here, but you know, Dr. Wiener will tell you that one of our quality metrics in our clinic at the VA is renin-angiotensin system blockade use. It's something he has to look at every year. Actually, again, I didn't have time to put it in this presentation, but I can give people the references. To this day, renin-angiotensin system blockade is underused. To this day, okay, in the community, perhaps even in nephrology practice. So this really highly vital intervention in diabetes needs a fresh look or needs a better look, okay? And I like to think in our VA clinic, we try and do our best. You know, we better have a darn good reason to think in our VA clinic for someone not to be on an ACE inhibitor or an angiotensin receptor blocker. Okay. So now I'm going backwards. Okay. So you'll recall in the beginning of the talk, I talked about VA Nephron D and the on-target study, both of which showed really poor results when combining ACE inhibitor and angiotensin receptor blockade to treat diabetic nephropathy. Okay, So of course, a natural target was going to be mineralocorticoid receptor antagonism. Okay? And this was a natural target to think of because the RAL study in patients with heart failure had shown such a phenomenally good survival benefit of giving people medications like spironolactone or allopurinol. Okay? But mineralocorticoid receptor blocker therapy had been limited. So to varying degrees, steroidal MRBs causing hyperkalemia, gynecomastia, worsening renal function. So in the past several years, several non-steroidal mineralocorticoid receptor blockers have been developed, and the one with which we're familiar is finerenone. And the ARTS-DN trial, the non-steroidal mineralocorticoid receptor blocker, in a proof of principle trial, showed decreased proteinuria in a dose-dependent manner with minimal blood pressure effect, and hyperkalemia was rare. And this diagram, undoubtedly drawn by someone perhaps in a manic phase, shows that aldosterone really has a number of interactions all through biology, whether it's immunology, whether it's cardiac remodeling and fibrosis, renal inflammation and fibrosis, blood pressure, tissue injury, reactive oxygen species. Mineralocorticoids were a really natural target, either as by themselves or as an adjunct to therapy. Okay. So these are the chemical structures of the steroidal and non-steroidal mineralocorticoid receptor blockers. You can see aldosterone, spironolactone, allopurinol, finerenone. So this you can see is completely different than the steroidal MRBs. And apparently it binds the mineralocorticoid receptor in a different manner that prevents recruitment of some of its partners to enhance transcription. I will leave that to the X-ray crystallographers to figure out. Okay. So 3 major trials have been done with non-steroidal MRBs, and this is sort of a CKD heat map to demonstrate which type of patients were in which type of drug. So in Fidelio DKD, these were patients who, kind of interest us, right? I mean, stage 3A, stage 3B, stage 4 chronic kidney disease with proteinuria. And the primary composite outcome you can read here. Figaro DKD had people who, this was primarily a cardiovascular primary composite outcome. And so didn't have people quite as sick with kidney disease. And in fact, they had some people with really G1, G2 kidney disease with proteinuria. What Amy Model, who was a nephrologist and diabetes researcher in North Carolina, calls the HFpEF of renal disease. So reasonably good renal function, but lots of proteinuria. And Fidelity was a composite of all of these. So basically all the data from these 2 slides. Okay. So I thought I would quickly show you the data from Fidelio DKD. Yes, trying to people get rid of it. Okay. Now, as I said, these were patients in which we were interested. Okay. You can see that a lot of these patients have chronic kidney disease, GFRs between 25 mils per minute and 60 mils per minute. Okay. You can see that they had a fair amount of proteinuria. Oh, proteinuria is down here, sorry. But they had a fair amount of proteinuria. And yeah, these are people in which we are interested. And what I thought was particularly interesting was that use of RAS blockade was almost universal. And use of some of the newer medications that were maybe not that new, but relatively newer medications, such as SGLT2 inhibitors and GLP-1 receptors, were absent. So this is really a non-steroidal MRB plus RAS blockade. Does it help people? And it does. I mean, you look at these forest plots. I mean, basically, whether you're talking about cardiovascular outcomes or for us, kidney outcomes, this medication was incredibly helpful. Okay. And probably why there are so many TV commercials for it. So I think it's undeniable that this is really a very good drug, that's an adjunct that didn't cause excessive hyperkalemia, that didn't cause excessive loss of renal function. In fact, it saved kidney function, and had a very low event rate for hyperkalemia. So the investigators then combined. This is from Rajiv Agarwal, who is the head of the Rodenbush VA nephrology section, combined the data from both Fidelio and Figaro And again, showed that whether it's cardiovascular events or whether it's renal events, finerenone was a winner on all counts. Okay. Of course, I do pay attention to the cardiovascular events, but I pay more attention to the renal events. And I think that the renal event data is a little bit more clear, certainly in terms of kidney failure, end-stage kidney disease, preventing a decrease in GFR or renal death. Okay? And the composites all favor finerenone. So this part of the talk, I think, really focuses a little bit more on, not so much that it doesn't focus on inflammatory mediators or things like that, but I think it's fair to say that in this part of the talk, I really haven't spoken about therapy for diabetes. What I've really spoken about is hypertension, cardiovascular outcomes, and the interruption of the renin-angiotensin system blockade. Okay? So for the next part of the talk, I'm going to talk about medications that have been made specifically to treat diabetes and how those medications impact on diabetic kidney disease. So, because of issues with rosiglitazone, the unforeseen cardiovascular complications that occurred with rosiglitazone, the FDA has mandated that every new anti-diabetic drug has to be found not to have any cardiovascular complications. Okay. So the way the trialists do things now, investigators either from academia or industry seek to design a study to test the effectiveness of a new anti-diabetic drug. As I said, the FDA has now mandated that all new medications to treat type 2 diabetes mellitus must be proven to be without what's called a major adverse cardiovascular event, or MACE. And the investigators are going to measure their usual cardiac parameters, what we call the three-step MACE, which is non-fatal MI, non-fatal stroke, death from any cause. But you know what? Renal parameters are pretty easy to measure too. Pretty easy to measure a creatinine, whether it doubles. Pretty easy to measure whether someone gets new onset microalbuminuria, or if the microalbuminuria transitions to macroalbuminuria, or if someone reaches ESRD. And so we have all of those metrics to look at. And then we close the circle, hopefully, by looking for dedicated renal outcomes. Okay? Now, we're talking about patients with heart disease, and we're talking about patients with diabetes. Two rather large populations in this book, which allows us to really generate a lot of renal data. And it is, as Kathleen Tuttle likes to say, the gift that keeps on giving. So let's talk about a medication that was made to treat diabetes, okay, SGLT2 inhibitors. And I'm not going to go over the cell biology of SGLT2 inhibitors and the channels that they act on and how they inhibit toll-like receptors and innate immunity. I've done that once. It was way too exhausting. I'm not going to do it again. But I think that we all understand the pleiotropic effects of SGLT2 inhibition. Okay, in our world, we have natriuresis, we have afferent arterial or vasoconstriction leading to a decreased GFR, but also resetting TGF through adenosine pathways. In the diabetes world, there's glycosuria, which eventually impacts beneficially on the heart. And so Hans Hirschfink, who wrote this review in Circulation, made another slide which he called the nephrocentric view of SGLT2 inhibition. So there's proximal tubular natriuresis, restoration of TGF, a decrease in intraglomerular hypertension, and then all the things that we like to see. Okay, so decreases in inflammation, decreases in albuminuria, decreases in blood pressure, decreases in glucose, everything that we want to see. Because remember, in all of this, whether it's the kidney, whether it's the heart, whether it's the eyes, whether it's the vasculature, whatever you want, the prime mover is hyperglycemia. Okay, so you have to treat the hyperglycemia. Okay. And there have been any number of major studies on SGLT2 inhibition with cardiovascular outcomes or renal outcomes. And perhaps hundreds. These are some of the top four that I was able to find. So this is sort of the John, Paul, George, and Ringo of SGLT2 inhibition. And I think if one were to read one that probably is the most important, it would be this one. This is the one that kind of pushed the envelope to start giving people SGLT2 inhibitors with GFRs as low as 25. Now, again, I'm not going to go over all of the data on those, but I will say that where there are trials, there are also meta-analyses. And this is from Oxford University, the Nuffield Department of Population and Renal Studies, published in the Lancet, called the SMART-C Consortium. And looking at basically some of the major trials, some of which I had on the slide before, one can see that SGLT2 inhibition has not only terrific cardiovascular benefits, hypertensive benefits, but really major benefits preventing further loss of renal function in patients with diabetes. Okay. Now, in some of our conferences, question and answers, case presentations by the fellows, there's been discussion, for example, in IgA nephropathy, whether or not one would give a patient with IgA nephropathy an SGLT2 inhibitor. Okay. Where does that data come from? It comes from this study. There's an appendix to this study. You can see here with glomerular disease, okay, some of the beneficial impacts of SGLT2 inhibitor on glomerular disease. And an appendix to this study, a lot of those patients with glomerular disease that were treated with SGLT2 inhibitors had IgA nephropathy. Okay, so this is where it comes from, right here. Okay, all right. So we'll try and put this together a little bit towards the end, because I think we'll be able to finish up fairly early. All right. So the next thing I'm going to talk about are GLP-1 receptor agonists and their role in diabetic kidney disease. Okay. So you may remember earlier in the century that a cell biologist discovered that a medication called a compound called exenatine, which was isolated from the saliva of Gila monsters, had profound glucose lowering effects. Okay. And this was called, these classes of molecules were called incretins. Okay. And we humans have them too, not just lizards, we have them as well. Okay. And there are several incretins. Okay. And probably probably the biggest, the most important one is glucagon-like peptide 1, which, like exenatine, does a number of wonderful things, including increasing insulin to decrease glucose. It's secreted by the gut. It increases satiety by decreasing gastric emptying. A number of things that one would want in a drug to control diabetes. The problem is that the half-life of these native compounds that we have is literally minutes, because, as you know, these compounds are degraded by an enzyme called dipeptidyl peptidase 4, or DPP4. Okay, so that engendered the creation of several new anti-diabetic compounds, such as DPP4 inhibitors, okay, and the creation of DPP4 resistant analogs that would act like incretin for a long time. Okay? So these compounds are derived from a propeptide that yields not just GLP-1, but also yields glucagon and this other compound called glucose-dependent insulin-tropic peptide. And you can see some of the actions of both of these, and we'll look at a study towards the end that shows combined use of these as a major significant weight loss medication. But in the central nervous system, GLP-1 agonism will lead to increased satiety and therefore decreased food intake and body weight. It does lead to a lot of nausea, right? I think, we talk about people who are taking semaglutide or liraglutide. Boy, do they ever complain about nausea. Okay? In the pancreas, there's increases in insulin, decreases in glucagon. Again, satiety is improved by decreased gastric emptying, but can also lead to really just bad abdominal pain, right? These are not easy drugs to take. And systemic, there's hyperglycemia with increased insulin sensitivity and decreased lipid accumulation. Okay? We know less about glucose-dependent insulin-tropic polypeptide, which everyone's called GIP. I'll just call it GIP going on forward. Okay, like other things, there is decreased food intake, so increase in better satiety profile. It can be used for weight loss. It increases insulin and insulin sensitivity. It also increases glucagon. So whether that's good or bad, we're not really sure. But both of these incretins are going to undergo, I think, there are going to be a lot of clinical trials looking at the role of these incretin molecules, not just in weight loss, but also as medications to treat diabetes. Okay, and we know the left side of the slide, there have been a lot of studies on GLP-1 receptor agonists. Okay, and because of the FDA mandate, we have a lot of cardiovascular data on GLP-1 receptor agonism. So this is a terrible slide for which I apologize. I couldn't find anything better. These are the commercially available GLP-1 receptor agonists. Just for your information, the medications like the glutide medication, semaglutide, dulaglutide, liraglutide, those are sort of humanized GLP-1 receptor agonists. The other ones, exenatide, lisexenatide, this exenatide XR, those are actually compounds that are based on the incretin from the Gila monster. Okay, so I think that's probably why medications like semaglutide and liraglutide and dulaglutide have become so popular, because they're really based on the human incretin molecule. Okay, so this is a meta-analysis again from Lancet Diabetes and Endocrinology, again demonstrating pretty much what I've shown you throughout this talk. There's basically a feeding frenzy of trials in looking at the beneficial effects of GLP-1 receptor agonism and whether it is cardiovascular outcomes or renal outcomes. I think I cut off the bottom of the slide, unfortunately. Yeah, so this is basically the cardiovascular outcomes, whether it's the 3-point major adverse cardiovascular events, cardiovascular death, or fatal or non-fatal myocardial infarction. By and large, regardless of which GLP-1 receptor agonist is used, there's a beneficial cardiovascular effect. And we ought not to be surprised by this, because the FDA approved the medication. So we knew that there was going to be a beneficial cardiovascular effect. Okay, but there is similarly a beneficial renal effect. Okay, so there are beneficial outcomes when this data was sort of recycled in a post hoc manner and looked at for renal effects, whether it was a composite kidney outcome, including macroalbuminuria, or worsening of renal function. I'll explain why worsening of renal function doesn't look quite as good as it does macroalbuminuria. Okay, and that's here because basically these patients were fairly healthy from a kidney standpoint. Their GFR was between 72 and 80. They had no significant proteinuria. The average length of follow-up was at best 2 years. Some of them were actually quite a bit less than that. Okay, so within 2 years, it seems reasonable to me that probably wouldn't be developing CKD that quickly, especially if you're starting from a relatively low risk population. Proteinuria, on the other hand, seems fairly reasonable to me that would be a marker that we could use and we continue to use. All right. So remember that these medications are diabetes drugs. Okay. And this particular study, called the Award 7 study, was an open label, 52-week randomized open label with a mass dulaglutide dose at 99 sites in 9 countries in diabetics with reasonable blood pressure control. And the intent of this study was to look at whether dulaglutide was essentially as effective an anti-diabetic drug as glargine insulin. That was the major aim. Okay. But a number of renal outcomes were measured at the same time. Okay. And so this is the table 1 in this paper is just disastrous. So I just kind of tried to emphasize the patient, tried to summarize the patient population down here and give you the idea of the renal parameters up here. So they had proteinuria. Okay. A lot of people had a fair amount of proteinuria. And they had chronic kidney disease. Okay. You can see that a lot of people had, EGFRs. The number of people with EGFRs that were quite good was actually quite limited. So these are people that I kind of care about, right? I mean, they have proteinuria, they have CKD. I need to do something about this. Okay. All right. So this was the diabetes. These were the diabetic parameters. Okay, this is the fasting blood glucose, and in fact, in the liraglutide group, the fasting blood glucose was actually a little bit higher than it was in the insulin group. Okay, so the HbA1c values, which I didn't put here, were close to identical. But the fasting blood glucose was actually a little bit worse in the GLP-1 receptor agonist group. They lost weight, as we would expect. Okay? The insulin group gained weight, the GLP receptor agonist group lost weight. But here's where the rubber hits the road. Okay? In a dose-dependent fashion, these patients who were treated with the GLP-1 receptor agonist over the course of the study lost less renal function. Okay? It wasn't very much less, but they lost less renal function. And remember, chronic kidney disease is a years and years and years long therapy. Diabetes is a years and years and years long therapy. And this is the eGFR by cystatin C. You can see by 52 weeks, there was much more, or statistically significant more loss of renal function in the insulin group compared to the GLP-1 receptor agonist group. And this effect was enhanced in individuals with macroalbuminuria. Again, this is people that we care about, right? They have diabetes, they have proteinuria, they have CKD, right? These are people who are at high risk of regressing to end-stage renal disease. And so while there was really minimal effect on the loss of renal function in the macro and the no macroalbuminuria group, the macroalbuminuria group, there was a statistically significant effect that's been recapitulated here in the bar graph. Okay. Okay. So that's an open label study. Okay. What about a small number of patients, right? Really a small number of patients, okay? So what about bigger numbers of patients, okay? So this was a study that was a post-hoc analysis, again, undertaken by Kathleen Tuttle's group that looked at semaglutide and type 2 diabetes with cardiovascular risk. And so they analyzed two large GLP-1 receptor agonist studies that were primarily done for cardiovascular disease, Sustain 6 and Pioneer 6. Okay? Again, we have we have a relatively large cohort of individuals here with CKD, okay? Now, it's important to realize that in Pioneer, patients were excluded if they had a GFR less than 30, okay? So like many post-hoc analyses, there's lots of holes in the data, okay? And so we kind of have to interpret it based on which holes we can fill and which holes we can never fill. Okay? They had also a fair amount of proteinuria as well. You could see the percentages here of individuals with proteinuria. And this was the annual changes in the estimated glomerular filtration rate over baseline to the end of treatment. Now, I think it was maybe Mark Twain, I forget who said this, there are lies, damn lies in statistics. So all of these are statistically significant. Okay, but which ones are clinically? Okay, the most clinically significant finding was actually for the group with an eGFR between 30 and 60. Okay. So there, at the end treatment date, there was a difference of 1.6 mils per minute. Okay, and this is where the fancy statistics come in that I don't know about. But there's a thing in the United States called the CKD Consortium. Okay. It's headed up by an epidemiologist named Laura Inker. I think she's in Texas. And one thing that she's pioneered is basically looking at the durability of a finding of GFR loss based on the slope of the loss of GFR. Okay? To the point now where the FDA approves looking at the slope of loss of GFR as a surrogate marker for drug approval. Okay? And this significant slope loss of individuals who are not treated with the GLP-1 receptor agonist compared to the relatively flat slope of this line and those who were was highly predictive of a significantly beneficial effect of GLP-1 receptor agonists in patients with a GFR between 30 and 60. And potentially a really significant addition to the tools that we can use to treat diabetic kidney disease. So what are the proposed beneficial effects of incretin therapies on diabetic kidney? So in animal models, this is really not very quantitative here, but essentially incretin-based drugs are thought to decrease expansion of mesangial matrix, decrease tubular basement membrane thickening, particularly decrease immune cell infiltration, restore podocytes, decrease interstitial fibrosis. GLP-1 receptors are, of course, found in the GI tract predominantly, but they are found in the kidney. They're found in proximal tubular cells and endothelial cells, what the thought leaders call the intrinsic compartment of the kidney. But they are also found in the extrinsic compartment of the kidney, or infiltrating cells such as lymphocytes and macrophages. Okay. And this is the only attempt at describing science that I'll make. I thought it was a really cool study. So in this Japanese study, type 2 diabetes mellitus prone mice called KK/TA Akita mice. Okay. They were treated with vehicle and with liraglutide, but with certain types of antagonism. Okay. So one group was treated with an anti-inflammatory, an antioxidant, a blocker of antioxidant effect. One was treated with a blocker of anti-inflammatory effects. Okay. And we can see in these diabetic animals, this fibronectin is sort of a surrogate marker for a thick basement membrane. Okay. We can see that there's loss of podocyte compartment. And if you see a foot process here, you're better than me because I don't see any. And this basement membrane is pretty thick, as we would see, in patients with diabetes. Okay. Now, when these animals were given a GLP-1 receptor agonist, but also concurrently treated with drugs that would potentially block downstream pathways on which GLP-1 receptor agonists would work, you still see these KWH-like lesions, increased fibronectin deposition, a decreased podocyte compartment, and these very raggedy, thick basement membranes. Okay? But take away the medications that potentially antagonize the beneficial effects of liraglutide, you have a clearing of the glomerulus with nice open capillaries, decreased fibronectin, an improvement in the podocyte compartment, and very nice podocyte foot process with a nice slim basement membrane. And that's represented graphically here. So that's the only animal model that I'm going to try and present. All right. Okay. So we now move on from just the GLP-1 receptor agonist to the possibility of a combined GLP-1 receptor agonist and GIP agonist. Okay. And this is primarily a weight loss study. So SURPASS-4 was a weight loss study where patients were treated with a combination GLP-1 receptor agonist and GLP-1 GIP receptor agonist. Okay. And again, these individuals all had proteinuria. None of them had proteinuria. Okay. They were as low risk from a standpoint of kidney disease as you could possibly get. And so these individuals received this particular drug, and they had excellent weight loss. Okay, really excellent weight loss. Okay? But they also measured some renal outcomes. Okay? And one could see that in those patients who were treated with, so the drug's called tirzepatide, okay, the combination of the two agonists, not only for weight loss but for diabetes. Those individuals that were treated with tirzepatide had a decreased new onset incidence of macroalbuminuria compared to insulin. And when you exclude macroalbuminuria, not as much of a great effect. But the key thing here is that the tirzepatide as a weight loss drug had an incidental beneficial finding of possibly preventing macroalbuminuria. So not only do you get diabetes control, you get weight control, and you get a, not preventative, I don't want to go that far, I don't want to use that word, but a modulator perhaps of diabetic kidney phenomena. Okay, so not all clinicians are simple-minded, but I think I am. And it's all well and good to have an open label study or to have some, post hoc analysis of gigantic data sets. But as a clinician, even though I have smart people telling me, Joe, you really need to respect the pragmatic trial data, or you really need to respect the patient-centered outcome data. what I want is the double-blind placebo-controlled trial with 1,000 people. Give me the results by the end of the year. Stop whining. What's the problem, right? And so Novo Nordisk said, sure, we'll do it. Okay, we'll do it. So this was the FLOW study. And you're going to wonder why I spent all this time on this when I give you the punchline. But the FLOW study was designed to look at once-weekly semaglutide versus placebo in patients who otherwise had, state-of-the-art care, ACE inhibitors, all that kind of stuff, right? Okay, and so they wanted to enroll people who had kidney disease. Okay, so the inclusion criteria were people either who had moderate kidney disease and a lot of proteinuria, and in those individuals who had less than high-dose kidney disease, or who had worse kidney function, they expanded the proteinuria guidelines. Okay, this was supposed to be a 5-year study. Okay, and basically was done to evaluate the effect of semaglutide on kidney outcomes, which is time for first occurrence of kidney failure, persistent greater than 50% loss in GFR, or death from kidney or cardiovascular complications. And again, this is the sort of schematic of the study here. It was supposed to be 5 years. I think they started enrolling in around 2019. Okay, you can kind of get an idea of what we're looking at here. Like I said, there are patients here who actually had chronic kidney disease. They had a lot of complications of diabetes, right? I mean, they had macroalbuminuria, they had diabetic retinopathy, they had all that kind of stuff. RAS inhibitor penetration was very high. Okay, so these people were given relatively state-of-the-art therapy. A lot of people were on metformin, they were on SGLT2 inhibitors. Okay, so it's not like they were not recruiting a cohort that was relatively well taken care of. Okay, and some of you may have heard this news at ASN. Novo Nordisk stopped the study because they have apparently reached all of their beneficial renal outcomes within 3 years. So the study was stopped. Okay. Now, I don't want to put words, I don't know if Dr. Canales is watching, I don't want to put words in her mouth, but she and I were talking about this yesterday. She was saying that sometimes stopping the study early is not necessarily a good thing. Of course, you have to do it for data safety monitoring and all that kind of stuff. But apparently it leads to an elevated point estimate. In other words, giving you a slightly better result than you actually have if the study is stopped early. This is an industry-sponsored study. You know, they have their data safety monitoring to which they must adhere. The readout for this is supposed to be in the first half of 2024. And I know that I'm going to be very, very interested in what this said. Okay. So in the last couple of minutes, I just want to sort of randomly go over a few things. Okay. So now we have non-steroidal MRBs, ACE inhibitors, angiotensin receptor blockers, SGLT2 inhibitors, GLP receptor agonists, insulin, metformin. I could go on and on and on. Okay, literally an explosion of therapies for not just for type 2 diabetes, but perhaps for diabetic nephropathy. Okay, what order do we get this in? Okay, what order do we get this in? What kind of combinations do we make? Okay. There's a researcher in Australia named Dr. Bruin. I didn't have time to sort of go over all of this stuff, but he has suggested that basically intensity of therapy should be based on the cardiovascular risk profile. So if someone has a really bad cardiovascular risk profile, you really need to front load these people with a lot of these medications. Okay. This particular study, the confidence study, and there's, if you look on clinicaltrials.gov, there's a lot of these studies that have been put up there, but I just picked one just because Amy Model, whose work I admire a great deal, is involved. So the confidence study is basically looking at either a combination of finerenone and EMPA versus finerenone and placebo, or EMPA and placebo. Okay, these people are not super sick, okay, but they do have diabetes, they do have diabetic kidney disease, they have at least one cardiovascular risk factor, and it's not a very long study. So we'll kind of have an idea of whether this particular combination is useful in preventing albuminuria, which is becoming the big surrogate marker. So what do we recommend today? And this is sort of a conglomeration of stuff from both the American Diabetic Association and KDIGO. It's actually a fairly well-written paper for people who might want to read it. You know, I think it's actually not bad for a physician paper. And it's called A Holistic Approach from the ADA and KDIGO. And I think the holistic approach comes from basically lifestyle. Okay. Now, you know, when people talk about holistic approach, you know, none of this is easy, right? Nothing that we see up here is easy. You know, they say shop the edges of the supermarket. Okay. You know, it's where the milk and the fruits and the vegetables and all that sort of stuff are. It's also where the most expensive food is. Okay. And so for people who may not be financially blessed, you know, shopping the periphery of the supermarket is not really very reasonable. Now, of course, you know, my dad smoked for 45 years. I can tell you it's hard to quit smoking. It really is. Physical activity, weight management, of course, you want to do all that kind of stuff. But what we really care about here, I think, is, yeah, how are we going to use the tools that are given to us? Okay? And I think this is a reasonable paradigm. I think we can all find fault with it. Okay. But I think upfront use of SGLT2 inhibitors and metformin with RAS blockade and statin therapy is certainly reasonable. But you know what? That paradigm may change given the great results that we see with GLP-1 receptor agonism. As I said, it's a really hard drug to take. Apparently, it's a very difficult drug to take. Pancreatitis, nausea, gastroparesis, just everything. But we have patients that persevere through dialysis for goodness sake. So hopefully they can persevere through this sort of thing. Now, here's where we start running into the problem of the great blessings of healthcare in the United States and the great curse of healthcare in the United States. Okay? All the medications that we're talking about that we are so delighted about, you know, and you can see here, look at this, SGLT2 inhibitors, benefit, 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 intermediate, SGLT2 inhibitors are not the greatest diabetic drug, right? Okay, low hypoglycemia risk, weight loss, cost is high. Same with GLP-1 receptor agonism. All these great benefits, the cost is high. Okay. And this is another paper from Dr. Tuttle. She went on, she and her group went on Pharmacy Checker and GoodRx to look at some of the costs of some of these medications in the United States. It's ridiculous. It's ridiculous, right? I mean, it's just absolutely ridiculous. Okay. So where does that leave us at the end? Okay. So I meant to say the plain old diabetic, but please spare a moment for the plain old diabetic. Many type 2 diabetics are older. They have a lot of comorbid conditions, including heart failure. Okay. They may not have adequate insurance to afford medications that could help them. The medical community's understanding of the pathophysiology of the cardiac and renal complications, certainly the clinical understanding, not just the cell biology understanding, when patients with type 2 diabetes mellitus is greatly improved. And I think that's greatly improved patient care for all of us, for everything that we look after. And I'm certainly grateful for more options to treat type 2 diabetes mellitus generally, and diabetic nephropathy specifically. I did a little bit of a back of the envelope calculation over the past couple of weeks when the fellows were presenting cases to me at the VA clinic. We actually have excellent penetration of patients with CKD that are being treated with a GLP receptor agonist and SGLT2 inhibitor. It's really excellent over there, right? Because VA is basically single payer healthcare. I mean, I was very surprised. You know, I mean, you guys were there last week. I mean, you know, we sort of look at it and go like, wow, this is really impressive. So I think we should look forward to the results of trials that will inform us how to use each of the medications and in what order. Confidence trial as an example. I think we need more collaboration. Perhaps we can create dedicated diabetic kidney disease clinics with our endocrinology colleagues. Okay. Chances are most of the patients we'll see are not going to have significant disease. Okay. But that means we can sure learn a whole lot more about how these drugs are used and contribute our input from a renal standpoint. We have to advocate. Okay. We individually in our professional societies have to lobby our governmental agencies and insurance companies to make life-extending and life-saving medications that treat type 2 diabetes affordable. Everyone says that about every single disease, whether it's inflammatory bowel disease or cancer or whatever, okay? But the latest USRDS report suggested that the ESRD program now costs the country between 25 and 27 billion dollars. Okay. So the question to me is not, can we afford these medications? The question to me is, how can we not? How can we not? Okay, because we're not just talking about kidney disease, we're talking about heart disease, we're talking about a whole lot of other things. Okay, that's all I got. Many, many thanks for coming by.
Question. If you don't mind going to the first slide where you showed the drop in GFR, it was a very nice slide, I think, even for fellows, I think.
Oh, sorry, I have to go back to slideshow.
Yeah, rate of fall in GFR.
What did you?
And I had a question. Like all the way, maybe. Next one, yeah.
This one, okay.
Yeah, it's a very nice slide. So I had a question about your thoughts on flow study. We are yet to see the results. I just wanted to ask you a question. So now if we see, if we weren't to do anything, the GFR was dropping around 10 in an ideal patient. And if we were to use ACE inhibitor, the loss is about 6 ml. So we cut down by half almost. Then if we were to use SGLT2 inhibitor and a mineralocorticoid receptor blocker, the drop in GFR is expected to be around 2.5 ml. We further cut it down in half. Now, in general, we tend to use these two medicines first, the SGLT2 inhibitor and ACE/ARB. Then our question will be, should we add GLP-1 agonist on that, top of that or not? That'll be our next question. Now, it looks like the bar is set very high for them because it's now 2.5 ml only that we have left to save as a protection for nephroprotective therapy.
Right.
Now, when they are doing the study, now it started in 2019, so I understand they are not required to have a SGLT2 inhibitor when they are enrolling the patients in a flow study.
Correct.
So now we're gonna see results hopefully in near future, and they'll show some stats. I'm guessing it's gonna be statistically significant. Now, question will be, if it shows 1 ml or 2 ml statistically significant, it will leave the nephrologist wondering, would that be the same effect if these patients were on SGLT2 inhibitor or not?
Yeah.
And that leaves a very situation of dilemma for that time.
Yeah.
So do you think it will matter that how much of a statistical significant drop or benefit we have achieved by GLP-1 agonist? Or do you think you feel still optimistic that if it's statistically significant, we should still consider it irrespective of patients being on SGLT2 inhibitor and
So I think the thing about these drugs, especially GLP-1 receptor agonists, is their pleiotropic effect, right? So for example, Dr. Tuttle's Award 7 study showed that it's an excellent anti-diabetic drug, right? And it's an excellent drug for weight loss. Okay. And I think that goes back to this guy, Bruin, who was in Australia, talking about almost boutique care, for patients who have either high cardiovascular risk or maybe they're obese or whatever. Okay. And so getting back to your question about the arithmetic, okay, you're right. If it's, just an improvement of 1 or 2 ml per minute. Okay. But if that's an improvement of 1 or 2, or a decrease in the loss of renal function of 1 or 2 ml per minute in someone with a GFR of 30, that's really important, right? I'll take every single thing I got at that point. You got someone with a GFR of 65 or something like that. I mean, again, they're expensive drugs, they're hard to take. And I might put that one on the back burner and say, let's see how we do with SGLT2 inhibition and RAS blockade and maybe non-steroidal MRB and stuff like that.
So in the flow study, I enrolled only 4 patients around SGLT2 inhibitors. But over the study period, the SGLT2 inhibitors have become the standard of care.
Right.
We don't have the.
4.2%. Yep.
Yeah.
So over the years, are more people in this population were also being started on SGLT2 inhibitors, or?
I don't know.
Yeah. That's probably.
Yeah.
But now the study is done, right? They're not enrolling anymore.
They're not enrolling.
They're done.
They stop it. Yeah.
And this is the baseline characteristics.
These were the baseline characteristics,
So we're gonna see results based on this.
Based on this, yeah.
Yeah. So they are not on SGLT2 inhibitors.
Yeah.
So it'll be hard. For me, it will be hard to interpret. That are they gonna still persist? They're gonna have statistical significant benefit if they weren't on SGLT2 inhibitor.
Yeah, no, I agree. And right, that's sort of the problem with these industry initiated trials to a certain extent, right? I mean, I think we had the same frustration like when I was a fellow. CellCept was just coming out. Yes, it was a long time ago. People were on azathioprine, and, cyclosporin was being transitioned to Tacro and all that kind of stuff. And you sort of look at these big transplant studies and it'd be like, well, we have this patient on like azathioprine, Santamune, and prednisone, and we're going to compare that to prednisone, Tacro, and CellCept and see which is better. Like, well, no one treats anyone with Santamune. Like, what the hell are you doing here? Like, what kind of comparator is that? And so, I think we have to. I mean, again, I'm not a clinical trialist. I'm just someone who takes care of patients. But I'm really hoping that wise people will create meaningful trials, using meaningful combinations of medicines. Again, I think the great thing about, as Dr. Tuttle says, the gift that keeps on giving, is that we're talking about diabetics and patients with heart disease. Like, there's millions of them. I mean, we should be able to recruit, reasonable cohorts with good statistical power for any one of these kind of patients.
Now that so many patients, non-diabetics, are also on GLP-1 to see.
Well, same with SGLT2 inhibitors. I mean, one of the things I forgot to mention was, the EMPA-REG outcome. Again, I think that was the study that really pushed everyone to say, number one, EGFR, you can go down to 25 mils per minute. Number two, we don't care if patient's diabetic or not diabetic. It works for everybody. Okay, and so and so going back to your question, then if SGLT1 inhibition inhibitor therapy is going to be that widespread, right? Diabetics, non-diabetics, GFR all the way down to 25. That's got to be like any. I mean, that's going to be like a background drug. Like, you're not going to have any respect for a trial that doesn't have RAS blockade and SGLT2 inhibitor, right? You're stuck. You're going to throw it in the garbage.
Dr. Arthur, mostly just a comment. I 5, maybe 6 years ago, I noticed just how relevant empagliflozin was in PBA. It was non-formulary, you click it, you order it, and that was before, right, all the waves came through and became before we knew all the foods for renal benefits. And so I remember placing patients on that, and I'm doing primary care there as a resident. And same thing with GLP-1s. We didn't need anything. We had to just order any of them easily for each patient. We're not worried about $100 a month. So I think that really helped, increase those numbers, right? Even back in the day, we were just starting to treat diabetes or maybe a little bit of weight effect, cardiovascular effect, and that as the trials kept piling on. We learned about yes, renal and cardiovascular. So I guess we've done well for a long time. So these is actually not the same. Respect. Just how they turned it around, how they got the contract right with Jardians so early on.
Yeah, they probably did. Yeah, so they were probably able to get it, pennies on the dollar.
Yeah, and it's an $8 drug for any veteran who is in full benefits, just like aspirin. You buy it to get a little aspirin, 90 days or 90% charges.
Yeah, so what she's talking about is basically at the VA, if you get a 90-day supply of aspirin, it's a $10 copay. If you get a 90-day supply of Jardians, it's a $10 copay. so
you buy the aspirin, you call it.
So a lot of these patients will be like, you know what? I'll go get my lisinopril, furosemide, all this sort of stuff at Walmart because it's I can get 100 of them for free. But my Jardians, I'll get at the VA.
Bitches.
Thank you.
Very nice.